Good morning, good afternoon, everyone. My name is Wendy Katherine. I'm the Executive Director of Health Nexus Santé in Canada, and I'd like to welcome you all to our session today on innovation in digital innovation in population health. We have an exciting group of panelists with you, and we'll be sharing information from on-market and off-market apps, as well as the opportunities for equity, discussions around policy, privacy, and some of the adoption issues around population health solutions in the digital space. This is a topic very near and dear to my heart, and I'm looking forward to forwarding the action on this issue, having heard from all of our panelists on the digital transformation that's underway and opportunities for dialogue around incorporating population health solutions at all levels of the system, including being co-designed by some of our vulnerable populations worldwide. And the excitement around those opportunities in the future will only grow. I'd like to turn our first speaker to introduce herself, Janet Hatcher-Roberts, on equity issues related to digital solutions. Over to you, Janet.
Thank you, Wendy. My name is Jan Hatcher-Roberts, and I co-direct a WHO collaborating center with Dr. Peter Tugwell on knowledge translation technology assessment for health equity. And so it's no surprise that that's what I'm going to be talking about today. I'm also an adjunct prof at the School of Epidemiology and Public Health at the University of Ottawa. In the past, I served as executive director for CSIH for many years and worked at the International Organization for Migration in Geneva. So we want to talk today a bit about global digital equity, addressing the divide and promoting well-being. And we've heard a lot about that this morning in terms of a promotion of well-being, not just health, but well-being. And we've heard a fair bit about equity and how do we try to ensure that. Now, so are we talking about what is fair, or are we talking about what is equal? So if it's fair, everyone gets an equal amount. Is that really what we're saying? And clearly the camel does not think what the mouse is thinking. And so we do have a differentiation between what is fair and what is equal. Health and equity has a certain moral and ethical dimension to it. It refers to differences which are unnecessary and avoidable, but in addition are also considered unfair and unjust. And that comes from Margaret Whitehead, who's been one of the big thinkers in this area. So what we're looking at are differences in health outcomes. We're looking at what's unavoidable and what's potentially avoidable, and then what's acceptable and what's unacceptable and unfair. And that's the inequity piece. And every community has a different definition of what's acceptable and what's unacceptable. And that's why equity has a spectrum of understanding. So equality means everybody gets the same opportunity, and equity means based on your vulnerability or what's deficient, you get an improved opportunity so that the opportunity is fair. Now, clearly, there's been other pictures developed from this where there's no fence at all. So this helps you understand the differentiation. Now, traditionally, when we look at evidence, we looked at how did something respond around the mean. So if we're talking about digital applications, did everybody use the app? Did the majority of people think it works? And that's good, we're good to go. But we really need to think about those populations who weren't responding around the mean. Are they more vulnerable? Are they rural? Are they urban? Are they women? Are they literate? And that's what we really do and we promote at our collaborating center, and that's how we work with our partners, is to look at what's going on at the tails of the curve, so to speak, around evidence. And that gets at this whole essence of inequity through Campbell and Cochrane collaborations, but now working with de novo evidence and interventions. So this brings us to the staircase effect, or the challenges to efficacy. If you're working in a research setting or an ideal situation, you may have an application such as a digital application that has an efficacy of 86%. But the challenges to that diminish the effectiveness at the community level, which is really what we're interested in. And that could be accessibility, diagnostic accuracy, provider compliance, consumer adherence. And finally, you can move from an 86% efficacy down to a 12.6% community effectiveness. And this is why we often see in an ideal situation something working, and when we roll it out or scale it up, it doesn't work because we've not taken into account all of these issues along the way, along the staircase that may affect that. So context is important. Having a digital application that connects me to a health professional is great, but I don't have the required bandwidth, and my husband keeps the phone to himself when he leaves our home. Do we all get the phone with the app, or how come some of us in the community are getting it and others aren't? So we really need to think about where is the community and how ready are they for this intervention? Have we just arrived in this community having had some chats with a few leaders to say, this sounds good? Is the community defining themselves even as a community, or have we defined that community? Is there an acceptance of the need to even address the problem for which this digital solution is supposed to solve? And so what are some of the challenges that need to be addressed in this particular community, and are they prepared and ready to work with this program or intervention that's available? And then we have to look at the cultural and context specific issues in each community as we roll this application out. And finally, are we evaluating the success, and how does the community evaluate the success? Often we're caught up into evaluation processes that are defined by donors or funders, but they may not be the indicators or the measures of success the community has. So we have to begin to bring those two ways of thinking together while we're going through a health equity impact assessment process of looking at potential impacts, looking at effectiveness, looking at mitigation, dissemination, monitoring and evaluation. So that whole piece is going along, which is our traditional impact assessment, as we have to interact. And we really feel this needs to be a continual interdigitation as we move through this health equity impact assessment. So not all digital technologies have an equitable impact. Just because it's inanimate doesn't mean that the impact is inanimate. So what are some of the first early steps we can take? Well, what we're going to hear from Clarence is that we need to examine existing platforms and opportunities. We need to agree on what characteristics might contribute to making a person or a population vulnerable to health inequities. And we need to make sure that our digital tool is not having an inequitable impact. There are methods and approaches that we can use to promote an equity lens, and we want to assure you that they're available and that all of us are here to work with you to make sure that as we're developing something or evaluating something, that we can ensure this equity lens. The first approach is we've named Progress, which started in terms of being able to evaluate existing interventions and looking at systematic reviews and re-examining them with a lens for equity. So we're looking at residence, ethnicity, gender, religion, etc. And then we realized we had to add to that to look at particular personal characteristics associated with discrimination or exclusion, features of a relationship, and time-dependent relationships. So all of this has been added in to our evaluation of the evidence, whether it's qualitative or quantitative. But they also can be considered if you're considering a new intervention or program. And this gets us to the health equity impact assessment tool, which is a workbook already that people can access. It was produced by the province of Ontario that Wendy was involved in and I've been involved in over the years. And this really takes a program or a policy and causes you to look at it. So if a digital intervention is part of embedded in a wider program, or if there's policies that are impacting on this aspect of digital technology and applications, we need to know whether they're going to be equitable, whether they've considered some of these issues. And the Health Equity Impact Assessment tool allows you to ask those questions. So now we'll hear some of the activities that are going on around the world, and I thank you for this opportunity to discuss, and we're always willing to collaborate. Thank you.
Thank you very much, Janet. We'll be hearing a video now from our colleague Clarence Baxter from Australia, who will introduce himself.
Hello, I'm Clarence Baxter from the Queensland University of Technology in Brisbane, Australia. First, many thanks to the event organisers for this opportunity to contribute to the panel discussion on opportunities for digital innovation in population health. My presentation is entitled SensorBased MHealth, and it arises from research published earlier this year concerning mobile health applications that use built-in smartphone sensors for diagnosis or therapy. There are 3 billion smartphone users worldwide, and right back from the days of the IBM Simon device in 1994, one of the hallmarks of smartphone technology is the use of apps to extend the functionality of devices well beyond simple telephony. There are 4.5 million apps offered by popular application stores. The Google Play and Apple App Stores emerged around 2008, 2009. And since then, we've grown over 1 million apps that focus on health and well-being. In 2011, the World Health Organization acknowledged mHealth as medical and public health practices that use digital devices. Wind forward almost a decade, and the WHO reviewed progress in this field and issued some words of caution, stating that an overwhelming diversity of digital tools is available, many of them being short-lived implementations, pilot programs, research apps and the like that don't translate into clinical applications. But the ones that do, there's limited understanding as to their impact, both in terms of health systems and the well-being of people. And lastly, they stated that rigorous evaluation is needed to generate the evidence required to promote appropriate use of this technology. So, how do we find safe and effective mHealth apps? Most people resort to search engines and, to a lesser extent, application stores to find mHealth apps. There are issues with the provenance of the data returned as search results from both these search types. Star ratings and reviews might not be reliable indicators as to the quality, safety or efficacy of a given app. So where do health professionals and health consumers alike go to find safe, effective, trusted apps? A group of websites have emerged referred to as curated third-party mHealth app libraries, sometimes called health app marketplaces. These sites perform curation activities, vetting, if you like, to screen apps to assert safety and efficacy before including them on their advertised list of apps for each website. It's in this realm of curated mHealth app sites that this research sits. We had several research questions in investigating this topic and considering those curated or trusted mHealth app library sites. Do they offer active smartphone applications that use built-in smartphone sensors for diagnosis or therapy? And if they do, how many are available? Regarding any identified apps, are they cross-platform compatible? Are they available for popular smartphone types and therefore available to the most number of users? Are they offered for diagnosis or for therapy or for both? What smartphone sensors are employed most frequently in these curated active mHealth apps? What conditions do these apps address? What health conditions? we looked at a total of 1,200 apps across 3 popular third-party curated mHealth app sites, and with duplicates removed and applying inclusion and exclusion criteria to identify those apps using built-in smartphone sensors, we found 18 apps across the 1,200 surveyed that use built-in smartphone sensors for diagnosis or therapy. With that, that's about 1 to 3% of the offerings from each of those 3 popular sites. In terms of cross-platform availability, only a third, or just a bit more than a third of the apps are available on both Android and Apple smartphone platforms. 50% of the apps that were identified are dedicated to the Apple environment only, compared with 11, which are solely Android based. The purpose of the 18 identified apps, about half of them are dedicated to therapy. A quarter, or a bit less than a quarter, dedicated to diagnosis, with 28% offering combined diagnosis and therapeutic functions. The most frequently used phone sensors in these apps are cameras, touchscreens, and microphones. Less frequently used, or not used at all, are GPS, accelerometer and gyroscope, and the barometer. The health conditions where these apps are employed include respiratory conditions, using the smartphone microphone to detect breath sound, dermatological conditions, using the camera to take images of skin conditions, and so on. So in answer to our research question, yes, active mHealth apps that use built-in smartphone sensors are offered by these third-party curated websites, but only 18 in the ones we sampled. Regarding these apps, only a third of the identified apps were cross-platform compatible. So there are opportunities there to increase the availability of apps to users of different smartphone types. Are apps available for both diagnosis and therapy? Most are therapy-based apps, with a smaller proportion combined diagnosis and therapy-based. The most frequently used smartphone sensors, cameras, touchscreens, and microphones. And the health conditions that these apps address, there's a limited range, including respiratory conditions, dermatological conditions, neurological conditions, and some mental health conditions, particularly anxiety. Now, it might be that diligent curation by these health sites is the reason that we see so few sensor-based smartphone apps in them. There may be an aversion to the risk of including such apps in their trusted libraries. There may be regulatory requirements which further contribute to the low number of apps observed. So opportunities abound for health improvement by growing the availability of mHealth apps that use built-in smartphone sensors. But this is contingent on evidence regarding their safety and efficacy, and therefore their suitability for inclusion in curated trusted sites for wider distribution. Thank you for your time.
Hi, I greet all the panelists and all the audience who is listening. I am Sandra Orci. I have a background in public health in the Mexican government. I have master's studies in global health at the University of Geneva, and I'm a research fellow in the Geneva Transformative Governance Lab at the University of Geneva as well. I'm going to talk about Ash Integral, an app that is aimed to improve maternal health and the challenges for its implementation and scaling up. I can't. I divided the presentation in 4 parts: the alignment with the Sustainable Development Goals, SDGs, the app, Ash Integral, and the deployment, the challenges for its implementation as well. Well, maternal mortality is a global health problem that is targeted with one of the SDGs, the Sustainable Development Goal number 3. maternal mortality has about 300,000 maternal deaths per year. That is 94% of the occurring in low and middle income countries. Whereas in countries like Canada and Switzerland, there is a maternal mortality ratio of 10, and it's relatively low, and 6 in Switzerland. In other countries in America, for example, compared to Canada, it's 3 times more in Mexico, for example, and in Brazil, 6 times more. In Nigeria, the problem is much bigger, where it's 90 times the Canadian mortality ratio. And the most important part of it is that almost all maternal deaths can be prevented with high quality care systems. So in ASH Integral, we see this as a health system problem, where of course there are inequities in the access to healthcare, a lack of participation of women to healthcare as well, but also health professionals and hospital managers have not enough resources or are unable to perform their daily tasks well, or even have insufficient training. Governments and international organizations sometimes lack a good diagnosis or inopportune decision-making, that make them have inefficient use of resources. So we have a communication or an information flow that goes in one direction. And in ASH Integral, we want to break this slow and linear process to have a 360-degree evaluation of maternity care with an app for women empowerment in healthcare. Our goals is improving women's experience during pregnancy, childbirth, and postpartum by tracking their health, and improving also the quality maternity care by identifying improvement areas. We will do this offering a health system perspective, facilitating the communication between different stakeholders, and combining science and policy. In one side, we have this in our platform, like women experience and health outcomes. And in the other side, we have the traditional indicators of hospitals. ASH Integral will analyze this data and report them to different stakeholders in different dashboards. So right now we're in the phase of programming and finalizing programming and piloting as well, with the support of the Ministry of Health in Guerrero, Mexico. We're going to pilot it in Mexico, in Guerrero. And after this interaction that has been essential, this communication with the Mexican government has been really important, we will have the final product and then scale it up in other regions with the support of local partners. So the main challenges for local implementations. Of course, the system part is very important. The interoperability between the app and the systems of the Ministry of Health, for example, in Mexico, and also the hospitals and healthcare facilities. Also the security issues and connectivity is very important. In terms of inequities, for example, there are some regions that do not have access to internet and Wi-Fi at all. Other thing that we are taking care about is the ethical and legal issues. We already have the authorization of the ethical committee in Mexico in the state of Guerrero. That takes into account, of course, data privacy, and we're taking care of data protection and to limit the responsibility of the app. And thirdly, how to engage stakeholders. As I've said, communication for us has been essential since the very beginning of the process of the development of the app. The understanding of the needs of each stakeholder and focusing, of course, always in women. We have this, we call it a women-centered tool. So we need to take into account the literacy level of women in each region. Of course, there are also cultural barriers. Evaluation and transparency perhaps is very common in some countries and regions, but in others perhaps are not so common. And also regarding the democratization of health, for example, in some regions it's politically correct to talk about women empowerment, and WHO talks a lot about women empowerment, but in some countries perhaps it's not so easy to talk about it. So we maybe need to talk about women participation, or even only informing women in certain things. So it's important to understand and respect the barriers. Also, of course, we want to change everything, but it's important not to force it. And finally, for scaling up for every early stage project, we need to think about sustainability, how we will get the funds through crowdsourcing, investors, grants, or public funds for next steps. So that's what the issues we have been founding in Integral, an IMHealth tool to improve maternal health that can be locally adapted. Of course, I am very eager to have questions if you need to, and of course to collaborate. Here are my contact details. Thank you very much.
Mark, you can introduce yourself at the beginning.
Great. Okay, great. Thank you very much. I wanted to thank the panel and Wendy for inviting me to speak today. And I'd also like to recognize all of our amazing team and collaborators at Born Ontario. I know that Marin's on the call right now listening, and she's really been the heart, soul, and hard work behind the upgrade for our app that I'm going to talk about today. So Omama is a pregnancy companion for trusted information, and similar to the previous talk, we're going to go into a little bit more detail about an app that has been rolled out in the province of Ontario. It's going through its next iteration to V2, addressing equity issues, making sure that it's available for all segments of the population. But it also has the ability to be adapted to other countries in the world stage. So one of the biggest challenges we heard from pregnant people was the ability to get accurate information about their pregnancy. And that was the real driver to developing this app, was to provide an accurate, reliable resource for pregnant people as they went through their journey. In no time ever has care changed. I am currently in several administrative roles as well as a frontline healthcare provider. And in some of our service lines, up to 70% of our care is now virtual because of COVID. In maternal newborn care, it ranges for low risk up to 50%, and in high risk as much as 30%. So it is very possible to provide remote and virtual care. The Omama app that's been designed is really a what to expect when you're expecting a companion for pregnant people, that has information on their choice of birthplace to information on parental leave and pregnancy options. One of the features it has that a lot of pregnant people have given us feedback they like is just the size estimation of the baby at each epoch of the pregnancy. So it's comprehensive and accessible. It's downloadable from both the iTunes site as well as Google for Android devices. It has a strong user interface. It's evidence informed and curated. It's currently in English and French, which are the two official languages of our country. And there's ability to securely save a photo, a document, and a journal entry. So everything from when a pregnant person registers onto the site, it guides them through each epoch and provides information and resources for what to expect. So for example, at 12 to 14 weeks of gestation, they would be instructed about prenatal screening, what it is, what it means, and what the results, how to interpret them. So the strength of this app is user engagement, and it was involved in the design. Very much interdisciplinary approach between midwifery, family medicine, and obstetricians, and it's reliable, trusted information. That what we've learned since we launched this in 2015, it's important to keep the contents and links up to date because they're always changing, as well as the information is dynamic. Keeping up with the pace of technical change and users' expectations of the interactability of an app and increasing user expectations. All of these are things that we're considering in the current upgrade of our app. So what's next? So the empowerment of patients and the democratization of healthcare is improving and really changed the way as healthcare providers were providing information to our patients. Lots of portals on information that they get their pathology reports, their ultrasound reports, even before they see their physicians. And so we would really like our app to be bi-directional, which is not now, so that we push information to patients as well as they put information that are stored in the registry. At the moment, it has links to the web, but not with our registry. We'd like it to have flags and alerts to risk stratify patients, for example, for those at higher risk of gestational diabetes or preeclampsia, to make sure they get the appropriate tests and interventions. Another part is diversity and inclusion with languages. Although French and English are the official languages of our province, there's both a very large speaking Arabic community as well as Mandarin Chinese. And ultimately, the interface with all digital information with artificial intelligence and machine learning to provide risk stratification, to provide notifications, and also to be a source for questions and answers for pregnant patients in the future going forward. So thank you very much.
Yes, thank you. Thank you very much, Mark. And to our earlier speakers, we'll now be hearing a video from the International Association of Medical and Pharmacy Students, and thank them very much for preparing this for the Alliance for Health Promotion. Cue video, please.
No. Hi everyone, my name is Hera and I am the Chairperson of Public Health at IPSF, the International Pharmaceutical Students Federation. And today I'll be sharing with you the work of IPSF on innovation and health promotion. So digital health is the convergence of digital technologies with healthcare, living and society to enhance the efficiency of healthcare delivery and to make medicine more personalized and precise. The use and scale-up of digital health solutions can revolutionize how people worldwide achieve higher standards of health and access services to promote and protect their health and well-being. IPSF and our partners provide platforms for all students and healthcare professionals to develop their digital health competencies. In addition, by developing a strategy, IPSF is providing students with the requisite digital skills for the future technological shift, and our health hackathons enable students to have their first contact with digital education, which is provided in most university curricula. So the Beyond Health Hackathon took place earlier this year in collaboration with the IPSF Asia Pacific Regional Office and the National University of Singapore Pharmaceutical Society, which was sponsored by Sanofi. The hackathon brought together over 200 pharmacy and medical students across 18 countries to create a future where the preventable burden of influenza is a thing of the past. The hackathon was aimed at solving unique challenges that stand in the way of influenza vaccine uptake, whilst networking and being mentored by experts. And also throughout the hackathon, there were a series of webinars by these experts. The hackathon was a great success and something that we hope to continue implementing in the future. Our European regional office carried out a survey on how digital health is viewed across European countries, which helped to get a better idea of the reputation within Europe and allowed for strategic planning on this topic. Following this survey, they held the Digital Pharmacy Week, which highlighted the different domains of e-health, such as healthcare administration, telehealth, clinical information systems, disease registries, and other information systems used for education, public health, and healthcare management. We also explored the ways in which digital health plays a key role in the pharmacy sector. Combining the pharmacist with digital solutions can help reduce healthcare costs and improve the patient experience by allowing remote interaction with the pharmacist. This is similar to the utilization of other digital solutions such as online banking or product ordering online. Patient access to real-time medication could provide a link to help both the patient and the pharmacist improve medication-related outcomes, as well as enhance the adherence and improvement of patient engagement, as well as prevent medication errors. Outside of IPSF, we have also collaborated with FIP, the International Pharmaceutical Federation, and the FIP Young Pharmacist Group on webinars exploring the digital health world from a pharmacy perspective. Now I'll pass on to my colleague from IFMSA so she can also present the work done by IFMSA on this topic.
Thank you so much, Hera. It was amazing. Hi, everyone. Allow me to introduce myself. I'm Omrani. I'm the liaison officer for public health issues for the International Federation of Medical Students Association, the IFMSA. And I'm here to share and go a bit deeper on what IFMSA has been doing in our health promotion approach, especially during the times of COVID-19. So allow me to share my presentation. So first of all, so to begin with, as soon as COVID-19 has started, our organization, a federation that represents more than 1.3 million medical students from 135 countries, we wanted to act fast. And I would really love to highlight how COVID-19 has really unlocked the potential and the eminence of utilizing digital health technologies in order to combat the pandemic. And in IFMSA, we had designed the COVID-19 IFMSA response, which had many different technological and innovative solutions that linked all our organizations across the world in our efforts to combat COVID. But we also saw how COVID-19 has exposed and revealed a global epidemic of misinformation. And we wanted to address that, because such misinformation has really amplified how COVID-19 was a critical threat for public health and led to worsening of health outcomes. In order for us to do that, we believe in the importance of partnerships. So we decided to partner with the WHO and UNESCO to design a global survey that assessed youth, the impact of misinformation on youth and how to address that. So we designed a survey, and that survey was answered by 2,660 youth across the world in collaboration with 3 other youth-led organizations. And we discovered that 85% of youth double-checked the information that they received before sharing online, which really highlighted how they were always very unsure about the kind of information that was spreading regarding the pandemic. And the top 3 media channels that were used for the information is the WHO, newspapers, and TV news. However, such misinformation has really impacted the mental health of youth. More than 50% of them expressed tiredness due to the rush of information related to COVID, while 42% expressed the feelings of anxiety. And this really led us to develop another collaboration in order to help youth combat such mental health implications due to the misinformation. And we decided to collaborate with a specific department within WHO, which is the EP1 department, under the umbrella of health emergency. emergencies. And we conducted another global survey that mapped all the fact-checking organizations that are available, as well as the institutions, the NGOs, and other entities worldwide. And through that survey, we identified 182 initiatives from 62 countries. And these initiatives verified information related to COVID in 48 languages. We have also seen how there are certain regions that really had the most fact-checking organizations available. So significantly, we saw that the Americas and the Asia Pacific had the highest percentages, in Europe as well. However, in Africa and the Middle East region, they had the least fact-checking initiatives available. So our data really showed that misinformation and myths related to COVID has been really spread out through public figures as well as daily social media outlets, which really called on the importance of political engagement as well as supporting national initiatives and fact-checking organizations both on a country and global level, which is really one of the tools that digital health has been proven to be important in order to address the pandemic. And we decided to develop our own digital health tool, and we created a map in collaboration with the Rice University. And in this map, we used all the fact-checking organizations that we identified, and we made a publicly accessible, available map for anyone who wants to double-check whether the information they're receiving related to COVID is correct or not. And you can find the website where you can check these map present in all the 5 regions and to see whether this organization that you're going to use to fact check is good or not, and which languages does this fact checking organization use. So this is it, and please feel free to contact me or Hera for any further information about our activities. Thank you.
Thank you very much. We'll now go to Sara Wolfe, Director of Indigenous Innovation at Grand Challenges Canada.
Just to introduce myself, I'm Sara Wolfe. I'm Anishinaabe or Ojibwe from Brunswick House First Nation is my family connections. I'm of mixed settler ancestry with my Ojibwe roots, and I've been in Toronto for the last almost 20 years, although I wouldn't really identify as a Torontonian. I just want to acknowledge that I am situated as a visitor in the traditional territories of the Mississaugas of the Credit, and I just acknowledge the traditional territories of where of the people wherever you are also situated. My background is, as by way of being here today, is most of my career I've worked in healthcare. I was a nurse and I was a midwife for most of the last 2 decades, working primarily in perinatal health with Indigenous families within a Canadian context. I've worked in major urban centers like Toronto and the United Kingdom. I worked in London, but as well I've worked in very remote and isolated communities all throughout Northwestern Ontario and the James Bay region and Hudson Bay region, providing nursing care for communities in really remote, isolated communities, fly-in communities that don't have a lot of access to healthcare services, technological services, let alone even the education and other kind of access pieces that most people within a country like Canada get to have access to. Currently, my job right now is as the director of the Indigenous Innovation Initiative at Grand Challenges Canada. And Grand Challenges Canada is an innovation platform. Some of you might be familiar with it. It works in international development, supporting innovation with people closest to those biggest challenges in our society. And we provide seed funding and grants and help transition to scale some of the boldest ideas that have the potential for big impact. They work primarily in global health, but there's also a number of other streams that they've worked in, including the development of a humanitarian stream that works to advance innovation for people that are impacted by conflict. But I lead the Indigenous Innovation Initiative, which is a relatively new initiative within Grand Challenges Canada and their first domestic program. But we're working to provide supports and funding and resources for Indigenous innovators who have ideas to solve some of the biggest social, health, economic challenges within Indigenous communities in Canada. And we know that Indigenous peoples have lots of really great ideas. We look at innovation from very unique perspective. It's not just about something that's new or technological, but supporting Indigenous communities and Indigenous peoples to take the old ways, our old knowledges, our old teachings, our old values, our old ways and practices and knowledge, and bring it forward to a new context or a new situation. And we consider that to be innovation. Indigenous peoples are around the world innovative by nature, right? So it's one of our core values to be innovative. And the very fact of our existence and our enduring presence on Turtle Island and around the world is evidence that we've always known how to be innovative, pre-contact and even since contact. So that's a bit about me. Hoping again, like I said, I am not going to be repeating too much. I just wanted to highlight kind of 3 key areas when we're thinking about specifically the opportunities. I'm going to try and focus in not so much on the challenges, but the opportunities for consideration from an Indigenous perspective and Indigenous lens, but just what are the opportunities in digital innovation. And the 3 kind of buckets I'm wanting to address are kind of really around the access piece and the opportunities within access to knowledge, in particular for public health information, the idea and concept around control, but then also I want to speak just a little bit more about the community role as I see it. COVID has really shown us at a global level that that disparities and the challenges in our society have these disproportionate impacts. And a lot of the gains that we've made as a society to try to create a more balanced society and more equal opportunities so that people can, all people can reach their fullest potential, has really been a setback by COVID in a lot of ways. But what we've also seen are some opportunities to really start thinking about things differently and to use the digital transformations as an opportunity to equalize some of those disparities and those gaps, so we can try to regain some of those wins that we had kind of leading up to this global pandemic. And in particular, really focusing on those populations that have been underserved and really making sure that we understand who those populations are that are underserved. I think that the opportunity to enhance the knowledge translation pieces for public health information is a really critical aspect. So much of public health information has relied on individual level practitioners providing that information to consumers. But the whole digital revolution and being able to translate that information in ways that are culturally relevant, really informed by communities, but that can be really authentic and reliable, but also relatable, right? So, sometimes we tend to apply information in really blanket ways, but I think that with digital technology, we have an opportunity to make that content much more relatable to the communities that we're serving. The idea of, AI and advances in AI that we've seen, we have to be super careful about, but I think that there's an opportunity to really be intentional about the AI, the metrics and ways that gets built into the digital technology so that it can bridge those gaps for the underserved populations that we know are not getting that same access. The other opportunity I really see is just based on some of the work I've done as a midwife in working with marginalized and vulnerable populations in an urban context, is being able to support community members who really need access to service by bringing them into the healthcare system. And I think that there's an opportunity within health promotion in particular and public health to be able to help bridge that transition into the healthcare system at the right time and at the right place. And again, addressing it from that equity lens, as Janet was mentioning. That was one of the talks I did get to hear was Janet's, just talking about kind of bridging it in with that, using that equity lens and analysis. In terms of control, I think that it's, also a really important piece of it. Think about like the community and the population and how involved they are in guiding and controlling the digital technology. Using kind of grounding myself in Indigenous principles around, in particular, I'm thinking about reciprocity. It's like, how do we move beyond just thinking of it as an exchange of information, but really actually seeing it as like a reciprocity relationship where there's an exchange for mutual benefit, where we can all grow and learn and enhance and get things better for that next generation of people. But to get to that, we need to be able to have, all people fully participating in the development of different pieces of this, right? So having the communities that it's intending to serve really be involved in the development of the technology, in the development of the content, and in the development of the dissemination of those pieces. And it's a real opportunity to build in economic development opportunities for the communities that we're intending to serve, rather than just launching in with a new product that we think is going to help everyone. We need to kind of work from a community first perspective, and so launching into that is just really, how do we make these technologies people centered? Using a person-centered approach for mapping what it is that they need and what their priorities are. Wouldn't it be amazing if we could create like life journey maps that consumers could, link in different aspects of their life journey from infancy right through, or even pregnancy, right through until end of life. And we can start to create these maps and these pathways, and even building in like forward thinking kind of mapping, where we can start building in the goal setting and build incentives based on the motivations and the priorities of the users. But to get to that, you need to be able to go to the community themselves to build out what those priorities are, because they're the ones that need to be the ones that are identifying what the need is. So it starts with community identified and defined challenges, and so that they can define what the needs are, what the gaps are, what the priorities are, and then to also be able to tell those stories of impact. So those are the three things I wanted to highlight, was just, that community, it needs to be involved from the beginning, at the very start of it, but also ongoing, involved in that journey and building capacity and building opportunities at all stages and in all levels, from the decision making to the interface to the end user. Making sure that the community has has the control over the data, control over the technology, control over how the information gets translated even, and that access needs to look beyond the main kind of the frames of, we heard lots of discussion around the equity lens, but even like in Canada, thinking about access to these interventions, like we need to be thinking about how like the hardware might not even exist within some communities, right? If we think about the remote northern communities, they might not even have access to internet or broadband or Wi-Fi in their communities. But that's changing and that's shifting. And there's an opportunity to start kind of equalizing some of those imbalances, in particular within regions, so that we can create that more equal, more just society, and to leverage a lot of the gains. So there's been a lot of challenges and a lot of setbacks with this global pandemic, but I think that there's also been a lot of gains and things that we've learned about how to do digital technology very, very differently, especially within a healthcare context across public health and health service delivery. And I think that there's some really great opportunities to create a post-COVID environment that can be more equalized. That's all I have to say. Thank you.
We received a question from the floor that I want to address before closing, and to provide as well an invitation to the entire audience. So on the issue of gender neutral language, we've heard numerous of our speakers refer to pregnant people and or users, our population of patients, and person-centered. And I just wanted to clarify, with the celebration of pregnancy care, expectant parents, and of women's health, that you'll be increasingly hearing language about pregnant people, about expectant parents, and pregnancy care as a way of both celebrating growing families, as well as welcoming all gender diverse individuals to the conversation. And those terms will be increasingly used to identify family groupings of diverse origin, and also all different kinds of bodies, colors, types, and diverse subpopulations that will experience and contribute to the dialogue on pregnancy. So with that, I would like to thank all of our speakers. In addition, I'd like to please invite the audience to stay involved. This is an ongoing dialogue about digital innovation, both at the Alliance for Health Promotion, also at the Canadian Society for International Health, and at World Health. We'd like to make sure that this dialogue remains current and certainly engaged with audience members, developers, and people interested in digital innovation around the world. I'd like to invite you to go to the forum, where there's a chat group already set up for users and interested partners in digital innovation. We'd like to stay in touch with you, and do see that this conversation will develop between this 10th Alliance Global Forum and future World Health and Geneva Health Forums. So please do indicate your interest so that we can stay in touch with you. And I want to thank you all. Have a wonderful day and a wonderful afternoon at the rest of the conference.